So I will stop at this point and turn things back over to Dr. Vernino, so that if you have questions, you can direct them.
Well, David, hopefully you'll stay up here, and I'll invite the other panelists to come and get behind your nameplate up here. And at this point, you've heard a lot of information. I've got some questions in my hand that we can start with, but this is really a time for however long it takes to maybe answer some of the questions you have. And of course, as you probably surmised, we don't have all the answers. And hopefully we'll be honest about telling you when we don't. So you want to, all right? Does anyone want to start?
Any difficult ones, go to that table over there. Yeah. So easy ones.
Easy ones over there. So there's a few, yeah. There's one there. One of the questions that's here on the sheet is what's the current theory about the cause of the disease? And I think Dr. Robertson just mentioned that we're trying to find out, but we don't really know.
This is, I think, for Dr. Robertson. Can you talk a little bit more about the rifampicin study and why patients are recruiting for patients who have fairly recently been diagnosed?
Well, let's see if this can you hear me? I don't believe it. Yeah. That's actually a very, very good question. And we actually have a very good answer for it as well. The reason we are doing that is we think our best chance to alter the course of a major illness is to get it early. We fear that if we start too late, even something that might work early on, we might miss that. So in this study, we are only studying people early in the course of the disease. I probably will say no more than that about this. I would comment that rifampicin is a drug on the drug market in the United States.
Yes. This has been a question I've had for a while. Being that Parkinson's, the MSA is diagnosed as being Parkinson's initially, what is the expected length of life after the diagnosis? Do you count it from the time of the diagnosis of the PD or from when you first start having symptoms of incontinence and OH? How do you, I mean, there's no way, I'm sure, that you can really be definite on something like this.
Yeah, is this working? I anticipate that there will be questions about prognosis and life expectancy. Because we know this is a progressive degenerative disease and ultimately fatal as things progress. But I always shirk the answer to how many years I have left, because I don't think that it's, we can say kind of what the general average is, but patients are quite different in how they progress. I don't know that I know the answer to your question, which is if you say, well, maybe the average is 8 years from diagnosis. It depends on whether you got diagnosed early or whether you kind of got diagnosed with Parkinson's disease for a few years and they got diagnosed. So I don't know that I can definitely answer that one. But that's my take on it. I think we're talking about, in that ballpark of, 5 to 10 years. But, I think with good care and support, addressing some of the complications, people can live a long time with reasonable quality of life. So I think it's a bad idea to sort of get the clock running, mark the calendar, and decide when you're going to quit living, because that's what we want.
Hello? Oh. I had 2 questions for Jeannine. Speech. Hi.
Okay.
So my dad has MSA, and he has this continual runny nose. I mean, it's like he calls it a faucet. It just keeps going and going and going. Is that part of the pathology of?
I have seen that in patients occasionally. I don't know, is this working? Can you hear me?
Mm-hmm.
Yeah? I need to refer to one of the doctors for the reason why, but I have seen it occasionally, not in all patients, but in some. This one?
Oh, I should say that it really happens a lot when he eats. That seems to be the main trigger when he could be in the middle of a meal and it just start pouring out of his nose.
And I had a patient recently that complained of that too, but I don't really know the answer to that. You guys have any? No?
Sorry. Do you know what can you hear me?
Yes.
Do you know what medications he's on?
Aricept, Namenda, fluorocortisone, Metamucil, multivitamin, stool softener.
Well, I'm afraid I still don't know the answer. But I think that ingestion of food and savory substances can provoke increased secretions. For most MSA patients, though, they really aren't able to make as many secretions as most people. So it's surprising to me that I think that's a very unusual problem in MSA.
Okay, and then I had the second question for you, and that's about this modified barium swallow study that you were talking about.
Yes.
Would that come from a speech therapist who would
Yes.
be working with my dad in the home, or how could I get that ordered?
Usually it is in a hospital rehab setting. There's a speech pathologist that does the actual study. There's usually a physician, a radiologist present, and then there's a tech that's there. There are mobile units to do it that do it in rural areas. They'll come to a facility or a home and do it. It needs to be ordered by a physician. And in most instances, the patient needs to be seen by a speech pathologist before they have the modified done. They need to have a clinical eval first to see.
Thank you so much.
Uh-huh.
I think the way it generally works is that we refer our patients to a speech and language pathologist, and they send us a message back saying this person ought to have a barium swallow, and we order it and they set it up. And,
Okay.
goes out. So it's kind of coordinated.
This question is for Dr. Vernino. I hope I said that correctly. You spoke about constipation. My husband has that sometimes, but the main problem he has is the inability to control his bowels, and it will be like a big problem all at once. And I wanted to know if that was maybe part of this disease also.
Well, you got some comments.
Explosion.
Well, I think, as I mentioned, the control of the sphincter is a problem as well. So coordinating those things, and you can certainly overdo it with some of the things I mentioned. Some of these medicines like Miralax and lactulose really get things going, and other medicines that we've talked about like pyridostigmine also stimulate bowel motility. So I think everyone's a little different, and it may be that if you can figure out some timing to it, it may be possible to figure out a schedule when things are coming. Or if the other way, the constipation is not as big a problem, it may be possible to cut back some of the things that are stimulating the bowel movements and moving things along.
He just has no
Yeah. Again, maybe what I was mentioning earlier is maybe having some time during the day when you just, again, like we talked about timed urination and timed bowel movements during the day, which, again, if he has time to empty things out, then less likely things will build up to the point where the sphincter suddenly says, that's the only thing I think about. And again, sometimes people just need to look at what they're doing. All the water and all the fiber and things may be too much for certain patients' bowel, and other people need a lot more. So there has to be sort of an individualized thing. So I don't have an easy answer.
just want to add something to the previous question about the swallow part. If you are in a smaller community setting, you might be able to get a swallow study through a radiology department. I am personally biased, in favor of using a speech therapist, because not only can they do the study, but they can just give you some feedback on various things that are good for you. Or if you fail the swallow study, what kind of consistency changes in the diet might be helpful. Now, I don't know if a simple radiology center might or might not do that. So that's something to keep in mind if you decide to get a swallow study. Just keep in mind as to who is going to follow up if there is an abnormality and who is going to help you with it. So it might be helpful to involve these guys early in the process rather than just turn up after having a test, which is always tricky.
I have a question that is often asked on the Scheidrig or the Yahoo email group. I don't know how many of you may be on that, but folks are always writing in about the patients having, quote, seizures. And what they're describing ranges anything from possibly a low blood pressure syncope episode to what they say seizures that last quite a while and multiple times. I think they maybe have called the 911, the squad a couple of times, but then they don't because minutes or I believe a couple weeks ago someone said one of these episodes even lasted like half an hour. So can you address seizure-like activity? That's not one of those easy ones, I know.
Well, I'll try and I can get corrected. There is no known association with seizures we call epilepsy, where you have a natural predisposition for seizures with multiple systems atrophy that I know of. However, I've seen instances where people actually have a drop in the blood pressure and lose consciousness. We call it syncope. And they might have some jerking movements with it. And there is also a fancy term for it called convulsive syncope. And we've seen instances where that has been misdiagnosed as seizures. Now, I don't know the particular scenarios, it's difficult for me to comment, but it's very difficult because I do other neurology to have a loved one count time when your family member is shaking. What seemed like 5 seconds might look like 5 minutes. And so it's very difficult to keep in mind as to how long is something happening. But you can have a syncope where they can have few jerks with it and not necessarily be a seizure.
Thank you. Anybody else with questions?
I guess the other concern is that people can have other things, may not be part of MSA, but people who fall a lot and have head injury and then have confusion or seizures that don't go away really need to be evaluated, because even though it's not part of MSA, you get a hard enough head injury, other things can happen. So another reason not to fall down.
This question is for Jeannine. I know that the Lee Silverman technique is proven to be helpful for people, but it's my understanding that you have to be trained in that technique. Is that true?
Right. Yes, that's right. A speech pathologist goes through a certification training for it. The program's very structured. That's what most of the research is based on. It's very intense. It needs to be 4 times a week, a total of 16 sessions. It's individual therapy, and it requires a lot of energy and commitment on the part of the patient and the family and caregiver, because for the program to really be successful for longer periods of time, the patient needs to continue to practice and keep going even after therapy ends.
I guess one question is that are there other techniques for speech and language pathologists if they're not trained in this technique? Because I hear from people all over the country they can't find someone who has gone through the training. So let's say I'm working with a speech and language pathologist who hasn't done the training. Are there techniques?
There are techniques to address different aspects of it. one reason LSVT's been so successful is because it was designed specifically for Parkinson patients. You're actually retraining. For many patients, they don't feel like their voice is softer. It's very difficult for them to understand that, and so you have to retrain their brain, technically, to speak louder. Another thing that makes it real difficult is because we don't usually think about how loud we're speaking unless we're in front of a big group like this. And we're more involved with the cognitive aspect of it. We're processing that information. A lot of times with Parkinson-related disorders and with MSA, those patients have some short-term memory issues, or they develop them along the way. They need longer time to process what they're listening to, and they forget all about thinking about loudness. So the program is really good for that. As far as addressing different things, there are techniques we can use for speech issues like mumbling or improving articulation. There's things we can do to address rate and even voice quality. They're just not designed specifically for these type of problems. And there is a website for finding clinicians in different parts of the country, and I'll be glad to provide that for you, if that'll be a help, okay?
After 3 swallow studies in the last 2 years, with each one getting progressively worse, family members were advised to learn the Heimlich maneuver. Where can we get that done, and more specifically, how can I learn if I'm by myself?
There's a lot of places where you can go to learn. It's really actually a part of CPR training, the Heimlich is. There are certain facilities that will just teach that. A lot of community centers will do it. A lot of, even some Parkinson groups offer classes in that. Hospitals offer training courses and how to do that. I don't have more specific, but I know there's a lot of places out there that will train you specifically in that maneuver.
It's probably a good idea to get part of that to get basic CPR training. The actual teaching for the Heimlich probably takes about 5 minutes.
Yeah.
But it's good to know in the context of what happens if that doesn't work, and then so on and so on. Yeah, I think it's probably true of any caregiver who take care of any person with a chronic disease to understand basic first aid and CPR.
They teach a lot of this also at senior centers in your communities. You can check there. They would allow you to go even though you're not necessarily a senior citizen in your community. They will allow you to come in and go through those CPR classes and Heimlich maneuver classes at those centers.
So one other question that's on the sheet here that I was given is a question about the process for accessing clinical trials, and I think Dr. Kheman put up the individual link on the Shai-Drager syndrome website to clinicaltrials.gov, and certainly many of the folks who have come to our center for the rifampicin study have started there. Generally they get referred to actually Dr. Robertson's site, to the clinical coordinators who talk with them and find out where they're from and try to help them locate their closest center or what studies they might be eligible for. But I think that's a good resource. Rather than, of course, you can go to your doctor, but they may not be up to date on the latest things. So clinicaltrials.gov is where sort of the official site of what clinical trials are going on. And sometimes patients come and tell me, I saw a new study. What do you know about it? I don't know anything. I'll have to look it up. And then so, that helps your physicians too if you can keep up with things.
It's a mandate for anybody who's doing a trial to enlist it on clinicaltrials.gov if a researcher wants to publish anytime in future. So by default, any study that happens in US where they're doing a drug study of any kind will have to come up on it. So that's a great resource. You won't miss it. If there is a study going on, it'll go up there for sure.
It doesn't always list all of the active sites, but it will get you the contact information to get yourself started in terms of making contact for eligibility and locations. The other question on here is just about new medications and approaches, and I think Dr. Robertson just addressed those.
And we have a question right here.
A lot of the causes and effects of MSA make sense. But one of the ones that kind of stands out is that I think I read that 60% of the people with it start having, where they're acting out their dreams when they're asleep. And often that happens a couple of years before they start having other symptoms. What could be the possible cause of that, and how is it related?
Dr. Kheman needs to answer the question.
I'm not a sleep expert, but I think speaking to the sleep experts, I think there are other neurotransmitters that are involved that go sort of haywire in MSA, but I'm not sure if there's a link between the alpha-synuclein pathology in MSA and REM that is known. It is true that REM behavior disorder is more common in the alpha-synuclein-based diseases such as Parkinson's disease, multiple system atrophy, and Lewy body dementia. And all the three conditions, it's most highly
disorders. It's the dreams sort of have a general theme of danger, and often they feel like they're protecting their spouse from something. At least that's what I hear. But it could be, seems like sports and fighting off attackers are the usual dreams that come into play. But presumably, as Dr. Kheman said, something related to the degeneration, I guess, in the brainstem, where this switch should be turned on during REM sleep, and it's just not happening. Fortunately, it does give us a clue about the diagnosis, so we often ask about that. And there are medications that can really reduce that activity, which can, although we can't treat a lot of things, that's one that I think we can get a handle on usually with some nighttime medications.
I have a few questions. My father died 2 weeks ago from MSA. I would be surprised. I've studied journals of neurology for 10 years now. We've been to the Mayo Clinic twice. And I will be very surprised if the path comes back anything other than MSA. But I'm one of 3 girls. That's my sister over here. And I wondered about the occurrence. I think you, Dr. Robertson, said it tends to be more in men than women. Is there any kind of, do you know why? Are there protective effects from feminine hormones, or?
Well, I would say that we've seen 700 patients in Nashville. It's almost equal between men and women.
Oh, okay.
It isn't a large difference one way or the other. And now some people have reported slight differences, but it's not overwhelming.
It's not significant.
Yeah, right.
And the other question I had was, I don't know if this is more Parkinson's or also MSA, but I've read that both smoking and a high caffeine consumption, coffee particularly, not so much tea I've read, there seems to be some protective effect. Of course they don't advocate smoking, but are there any clinical trials in the works to maybe harness why nicotine seems to be protective, or?
Well, I think some others may have some thoughts about this. I think that first, caffeine has been studied in Parkinson's disease pretty thoroughly because people have wondered if it might help Parkinson's disease rather than hurt Parkinson's disease. Some patients with MSA will tell you that they stopped smoking around the time they started getting MSA. And when we have given nicotine to patients with MSA, sometimes they will have worsened shaking. So there might be reasons that people would stop early on with cigarette smoking, but it's also possible that there are toxins in cigarette smoke that are contributing to all of this as well. I think some people have felt that there are fewer people from cities who get Parkinson's and perhaps MSA than on farms. And there, the sense is that people on farms might be more exposed to kinds of toxins that might be causing Parkinson's disease.
Could be all the cigarette smoke in the city. I think that's a curious thing that people have noticed. We didn't believe for a long time that smokers had lower risk of Parkinson's disease. I don't think we know that the same is true for MSA necessarily. But it's also true that nicotine does provoke release of dopamine in the brain. So the other theory that I have no proof for, but I think it's maybe true, is that smokers are sort of releasing dopamine, and even though they may develop Parkinson's disease, they're treating themselves and delay the diagnosis perhaps until they get lung cancer. So they never get diagnosed. That's just a random.
It's a very big deal.
My question is about sleep also, and I'm from the South, so I have an accent. My husband's having problems staying asleep. He'll wake up 2, 3, 4 nights during the night, and some of it's to use the bathroom, and some of it is he's awake, so he thinks he has to go use the bathroom, and then some of it is breathing. He wakes up feeling like he's can't breathe. So would this be an anxiety issue, or how do you know? Is this related to the breathing difficulties of the autonomic?
It's a complicated question because sleep is a complicated thing, although, we sleep every day. It's very part of our routine. But there are two main issues with sleep, or if you can simplistically look at it, is trying to fall asleep and not being able to, or falling asleep but getting up early awakening. And there's so many things that can cause early awakening, and you've already mentioned one, which is maybe having to go to the bathroom. Number 2, anxiety. Number 3, motor symptoms of Parkinson's disease and MSA may get worse at night. People may be more uncomfortable, and that itself may wake people up. That's more common in Parkinson's disease because you can just turn off at night and be so uncomfortable that you can wake up. And you also alluded to something which is very important: sleep problems. Not only REM behavior disorder, but obstructive sleep apnea are more common in neurodegenerative diseases. And although we think REM behavior disorder is easily treated with giving medication at night, which is clonazepam, it's most important to make sure that the person does not have obstructive sleep apnea, because clonazepam can make that worse. So it is only through a very thorough history and talking to the patient, the family member, can you identify what exactly is the problem that is causing early morning or early awakening. And it could be a multitude of things happening at once and just not one thing. And ultimately, a sleep study called a polysomnogram may be able to identify if there's an intrinsic sleep-related problem or it's one of these other environmental things that is causing the early morning awakening. So the cause is not as simple as maybe just giving a medication. It needs to be identified. And if the neurologist is not able to do it, he or she may refer you to a sleep specialist who can ask you a very specific history about sleep. Because these are the very valid questions that need to be answered before you can identify the problem and treat it.
I have a pretty low threshold for getting a sleep study on patients with MSA, because there's so many different things: obstructive sleep apnea, and REM sleep disorder, and the nocturnal stridor with the vocal cords kind of going into paralysis at night. All those things can be identified. At least you can know what you're dealing with. And I think what Dr. Kheman says is very true, that in Parkinson's patients, and I would presume MSA patients as well, If you're getting a benefit of dopamine treatment and then it wears off at night, you can get very stiff, very rigid at night. And when the patient wants to roll over to get more comfortable, they can't. And they wake up. They feel like they're sort of trapped in the bed. And so we often ask patients, can you roll over in bed? And that's, they don't tell that story, but they'll say, yeah, that's a big problem. I can't move around in bed. You can imagine if you can maybe get to sleep in one position, but if you never change position, you're going to end up waking up and then have to kind of fight your way into a new position and fall asleep again. So that's often one. And sometimes carrying forward some long-acting dopamine into the night can help, but again, in MSA, that dopamine treatment is often not as effective as we'd like it to be.
And I must say that I didn't talk much about, at least in my talk, about mood disorders, and anxiety is actually quite common in neurodegenerative diseases. And in younger people with or without MSA, one of the most common causes of early awakening at night or not being able to stay asleep for the entire duration you want to could be depression and or anxiety. That's important.
I had asked this question earlier about a national database of all people with presumed MSA to determine their former infectious agents they may have had, or environmental factors, or head trauma, etc., to see if any of these could maybe statistically lead to these problems. And I know you have 700 people in Vanderbilt, and I'm sure you have all this information on them. And wouldn't it be valuable to try to get it from everyone else?
Well, I think that's a very good point. As you know, there is a website called Patients Like Me, where people do contribute comments. I actually go there to read and learn from what patients have discovered about themselves sometime. I would say that there is a little bit of a problem with a questionnaire and the control subjects. And here's what it is. If you come to a patient with MSA and you ask about drug exposures, and this patient has had MSA for a year or two, and so the person's been thinking about this for a long time and has really thought of a lot of drug exposures. That is, hasn't left any out. If you then go out into the hallway and just stop the first normal person who comes down and ask them about drug exposures, they won't have thought about it as much, and they might forget things that they were exposed to, and that might produce an artifact. I'm exaggerating about it a little bit, but the point you raise, though, the point that you raise about patients providing information on themselves through websites is an extremely powerful tool that's just beginning to be appreciated. 23andMe also is collecting information like this in Parkinson's disease, and sometimes they will even take MSA patients. They will sometimes take Parkinson's patients without charge. But that organization, which has a fair amount of money behind it, but has no physicians in it, I think, they recognize the great value of what patients know. I don't think I've answered your question very well, but maybe others can address it.
Yeah, I think we recognize there's a value there. There's those sorts of things that do them properly may require a lot of initiative and money as well. But, I think we're getting to that age, as Dr. Robertson said, where we can start to do a better job of collecting that sort of information. So appreciate your comments.
Going back to your comments about anxiety and depression, I'm sure this is, depending on an individual patient and their concerns, but would that anti-anxiety or antidepressant be helpful for a patient with MSA?
Yes, anxiety and depression would be treated in MSA like any, like anxiety and depression would be treated in anyone else. The cause of the anxiety also needs to be identified. And I think, again, a careful history taking is important as opposed to just giving a pill. And my colleague just pointed out a very important fact that I might have missed mentioning is laryngeal spasms. It can happen. Vocal cord paralysis can happen. You have this feeling of suffocating or choking. And that can cause a significant amount of anxiety. So in that case, giving a pill for anxiety is not going to do much. You have to identify what's going on. You know, where's the anxiety coming from? Is it coming from a physical cause? Is it coming from a laryngeal spasm? Is it coming from something else? So careful history taking is important. And after you determine that, you know, where there is no underlying cause, it's actually a mood-related disorder, and then absolutely you need to treat it like you would treat anxiety and or depression. Yeah, you have to just be careful about the side effects of those medications as well.
Is it dystonia, the kind of like the cramping or the the pulling of the muscles to one side? And I know I forgot which speaker, I'm sorry, but talked about some of the strategies behind exercise is good. Talk about Botox, but is that something that, I mean, those kind of strategies, does that reverse it? Does it just keeps it from getting worse? And are there other things you can do about it? Like, if it's in the face where it's really hard to exercise it?
We're talking about the dystonias and dyskinesias.
Yeah. Do you want me to take that? Okay. You're talking primarily of dystonia in the neck, I'm presuming?
Actually, she has it like in her like in the trunk, and then also some pulling of the muscles in her face.
Right. I think the first part of your question is it completely reversible? Not really. Rarely dystonia can spontaneously get better on its own, but in a progressive condition, you'd expect it to either stay the same or worsen. So if you identify it early on and treat it, you can decrease muscle contractions, but also perhaps prevent those permanent irreversible changes that can happen if a muscle remains contracted over a period of time, which I think I mentioned was like a contracture, a permanent contraction. So if it's identified earlier and it can be treated earlier, and it's true that dystonia of the axial or the back muscles is not as easily treatable as dystonia of the neck muscles. The back muscles are pretty extensive and very long, and sometimes you may need more toxin that you can give someone because you're afraid of the toxin can potentially paralyze diaphragmatic muscles, can travel to the pharyngeal area, etc. So you have to be really careful. You may not be able to reverse it completely, but you may be able to mitigate the symptoms for reasons of comfort and to prevent these permanent changes that can happen. And yes, you can give the toxin in your face as well to minimize contractions.
So is there something other than using the toxins? Is that pretty much a standard?
Other than using the toxin are the couple medications, 2 or 3 medications that are available that I talked about. One is clonazepam or Klonopin, the other is baclofen or lansoprazole, and baclofen is not very helpful. It's more useful for spasticity than for dystonia. In multiple system atrophy, both dystonia and spasticity can coexist, so it may be helpful. Do not discount the utility of neurorehabilitation and physical therapy. So we know for a fact from research that medications and physical therapy complement each other. So both need to be done at the same time to get maximal benefit. So yes, injectable agents, oral agents, and physical therapy. Lastly, the medications that are used for Parkinsonism, both in Parkinson's disease and multiple system atrophy, could be a double-edged sword in the sense that sometimes when you're off, you've decreased dopamine in your body, you can have dystonia. That can be countered by taking these medications. But unfortunately, if you have too much of these medications in your body, then you can get dystonia as well. So again, that needs to be sorted out, whether the medications are causing the dystonia or there's less dopamine in the body that warrants taking more medication.
So if the symptoms fluctuate, you need to communicate that or have a chart kind of pay attention to how they fluctuate if they do.
I have a kind of forward-looking question. I'm not sure where we are in the scale of, have we looked under every rock in terms of research, but are there any successful animal trials that haven't yet moved into the human phase that you know of? And I don't know what the reason would be, maybe for lack of funding, but is there anything that you're hoping is coming up on the horizon?
Well, we have two separate animal models for MSA now, and a number of trials are ongoing of different agents. I think that those studies are proceeding, and and for the foreseeable future, I think that that will be a major source of ideas for trying to move forward. But let's not overlook the possibility that in the area of in the era of the genome, things are still happening very quickly, like the copy number concept. That's not something that was discussed 3 or 4 years ago in genetics. The ability to sequence a human being's exome for $1,800. I mean, that is amazing. The whole coding region of the genome, $1,800. It's come that low. It was $1 billion, I think, a few years ago. So there's just a huge amount of information coming out. And I think there's every reason to be optimistic. Even if I haven't been able to tell you exactly where it's going to happen and can't promise that rifampicin is a drug on the way to doing that. But I'm absolutely optimistic that in my lifetime I will see a major change in the outlook in MSA.
Are there any other questions? Okay.
I guess I was most encouraged by your suggestion of having 1 or 2 glasses of wine every night. In that line of thinking, for a short time I was misdiagnosed as having MS. And there were some tests there with marijuana, if nothing else than to change your mood and things to help combat anxiety and things like that. Have there been similar tests in this area?
Not that I know of in terms of marijuana and MSA, not that I know about. The wine part, I just want to emphasize again, is just to make sure that your supine blood pressure isn't too high. But food works just as well, or hard drink just works as well. But yeah, but I'm not aware of any marijuana other trials.
Any other questions? Oh, yep. Okay.
Thank you. It was a blood pressure question. Sure. We gave the highs, a 180 and a 110, but we didn't discuss too much about, how low should low be?
Most of the times, people become symptomatic by the time it gets to, 80 or the top number being 80 or 90. One of the problems that happens is that there is a phenomena called cerebral autoregulation, and try not to get too fancy. It's the way your blood vessels in your brain compensate for the lack of systemic blood pressure or too much of a systemic blood pressure. And so with a period of time, people might become less sensitive to those spikes or drops in the blood pressure. And so in my experience, once it gets down to 80 or 90, the top number, most people become symptomatic. That's something to keep in mind. But the longer you have the disease, or the longer you have a neurogenic orthostatic hypotension, the less pronounced the symptoms may be, even though the numbers change significantly. Not necessarily everybody, but in some folks. That high number, and it is worth repeating, there is no one study proving that 160 to 180 might be okay for everybody. A lot of that depends upon the individual patient, and you need to work with the neurologists who you're seeing and sort of assess other risk factors that you might be exposed to and what might be optimal or not optimal for you.
We have some patients where the hypertension is a much bigger problem, and we get help from cardiologists to come up with. But there are certain classes of antihypertensive medications that are perhaps a little bit better in terms of not giving you so much trouble with the low end. But David has comments about how low is too low in your practice.
Well, I think that's true, but I might just make it a little more general question. If I saw a normal person, a person who had no complaints, no MSA, nothing like that, they just came in and said, my blood pressure is 80, my systolic blood pressure is 80 all the time, you might be interested to know that most physicians, and I wouldn't be one of those, if they had no symptoms and they were 80, I would accept that. I might follow up, once a year or so to be sure nothing changed, but I agree with those comments you've heard earlier. We look for symptoms in guiding us.
It really is hard with the upper end because many patients don't have symptoms of hypertension. And sometimes we get a big shock when it's 220 or something.
That's right.
Patients think they feel pretty good, but it's not something we want to let persist.
And I guess one other thing is that in treating hypertension in the general American population versus low blood pressure in diseases that we treat, the whole concept is different. In hypertension, we're never trying to make people feel better today with this blood pressure lowering pill. We're trying to prevent strokes and things 10 years from now. But in the low blood pressure field, we're just trying to get people through the day.
Is there any correlation with atrial fib with people with MSA?
I don't think so. I know that patients who have intrinsic heart disease like atrial fibrillation have a much harder time. They have a much harder time managing that. But I think that's just sort of adding insult to injury rather than a true pathological correlation of diseases occur together. And with some of these patients are who have atrial fibrillation are also on other medications or have a pacemaker, and that sort of limits their cardiac reserve as well in terms of how well they can accommodate blood pressure. So I think it's just another. We even have a patient with MSA who's got congestive heart failure from a number of heart attacks. There's not much you can do because his heart can't tolerate high blood pressure. His heart can't tolerate low blood pressure either, and so it's dealing not only with lightheadedness and fainting, but also angina all the time. So it's a big challenge. So and as people get older, they have the other diseases that everybody else gets too, that kind of add on top.
Just to follow up on a point that Dr. Vernino alluded to, and then somebody had asked me after my talk earlier privately, the supine hypertension, that's the high blood pressure when you're lying down, you can easily work with your cardiologist to get that taken care of. There are various short-acting medication which only work for like 6 to 12 hours or so that you could easily try that might be worthwhile helping that part just at night so that you might not be as exposed to low blood pressure in the morning. But it's definitely worth trying.
In one of the earlier presentations, it was mentioned that there's a DAT test measuring dopamine levels. Is there any correlation between your DAT reading and whether Cinemat would be effective for for Parkinsonism?
Let me understand the question. You said a correlation between taking Sinemet and what now? Sorry?
Reading your DAT level?
That's good.
The DAT scan was studied expressly to differentiate between normal and abnormal, if I understand correctly. The test does not have the discriminative power, at least if I understand correctly, as of now, to separate different kinds of Parkinsonisms from each other, like Parkinson's disease, from MSA, etc. So I think it just ends there. The DAT scan is abnormal. There's decreased dopamine uptake in the regions of the striatum, and so therefore there is a primary dopamine deficiency, but that's not exclusive to MSA. So supplementation of Sinemet is done, not necessarily based upon the DAT scan, but based upon the DAT scan plus the clinical symptoms of Parkinsonism. So everyone who has Parkinsonism or these motor symptoms merits a trial of levodopa to see if the symptoms improve. But I don't think the DAT scan alone dictates how much Sinemet one needs to get, because I don't think we are at a point we can quantify that and translate that to medication intake.
Dr. Robertson talked about the SHC2 gene in a large number of Japanese patients. Do you know if that's been followed up on, what the significance of that was, and is there any other studies that turned up any sort of characteristics that went along race or ethnic lines?
The Gaucher's disease gene is something that has been found to be associated genetically with Parkinson's disease for some time. So there is a relationship between Parkinson's disease and that. This copy number concept is a little different, and so it's still early days with this. And I'm not sure where that's taking us, but it sure comes back and points us again at a gene, a group of genes that are involved in a disease called Gaucher's disease, totally different than MSA or Parkinson's, and a tendency to get Parkinson's disease. So I think these are leads that we'll be following up on and seeing what we can learn. And I think it may also be helpful to see in these gene areas what the differences are between average Japanese patients and average patients from Europe.
Okay. It looks like we have been Q&A'd. I hope everyone's questions were answered. And hopefully the video that we're doing will be available so you can do a recap. It is our goal to give everyone, when we get the copies made, we will send you all a copy of the DVD that comes from what you participated in today. And that being said, I really want to thank Dr. Vernino and the excellent panel that he put together so that we could all come here and learn from one another. So thank you very much. Thank all you guys. And that being said, Chelsea Therapeutics and their wonderful monetary donation, because without money, this wouldn't be possible either. But most importantly, we thank you, the patients and the caregivers, because without you, there would not be a reason for this, and we don't really, any of us, ever want to be in this situation. But we are, so we just have to do the best we can, and our mission is to educate and support, so we hope we've done that this weekend. But along that same line, this information was all geared toward the patient. And as a former caregiver, I want to make sure that you caregivers take care of yourselves too, okay? If that means a day of respite every now and then, a pat on the back, venting through the support line with either Vera or myself, just don't forget yourselves. And patients, don't you let them forget themselves, okay? Because it's really important. We're all in this together. I told my husband many times, it wasn't his disease, it was our disease. And so if we work together, you know, we can accomplish bunches. So again, thank you all for coming. We're going to end, unless anybody has anything else to say in closing. Okay, we're going to end the video portion of this meeting. So they're going to cut the video off. We're going to do a couple housekeeping things. Then we're going to take a short break, and then off video, we're going to be breaking into caregiver and patient little small groups. You might have a question and you just want to ask another patient, or you might want to ask another caregiver that you didn't feel like maybe was a question that you wanted to ask, you know, the physicians. So, John, I think you have something. We don't normally do a lot of recognition for our board members, but unknown to me, yeah, that John, unknown to me during the summer, there was a little grassroots effort on those of you who might be on that Yahoo email group. And Vera, would you like to come up here? Vera was presented last night at our social hour with a laptop computer because she does so much for this organization. I think I told somebody I put in maybe a couple hours a week, sometimes maybe an average a couple of hours a day. This gal, she puts in about 5 or 6 hours a day sometimes, or more. During the last 2 weeks, you know, not included here. But she does so much that a grassroots effort came up, and people emailed thank you notes for Vera. And go ahead. And they have put them together into an album. I think I was told, bring the tissues out, that there were over 700 thank you notes in this album. So we didn't want to do this earlier today because we knew it should be a basket case the rest of the day. But that is, you know, and even though this was a grassroots effort, and you all have, a lot of you have just met Vera, you'll come to know her very well if you use a support line or get on the internet. And with her new laptop, she can look up even more research stuff for us. So again, thank you all for coming. Take a short break. There's desserts, more food, restroom break. Come back.